Well, good afternoon, everyone, and thanks so much for joining us today for this webinar during STD Awareness Week. Today we have Dr. Jason Zucker presenting a case-based webinar based on the STI treatment guidelines. Dr. Zucker is an assistant professor of medicine at the Columbia University Irving Medical Center and the assistant medical director of the New York City STD Prevention Training Center. He is trained in adult and pediatric infectious diseases and has extensive experience providing sexual health care to patients of all ages, as well as providing technical assistance and training around sexual health to clinicians. His research interests focus on how technology can be used to optimize the cascade of care for adolescents and young adults at risk of HIV and STIs. Welcome, Dr. Zucker, and thank you so much for your presentation today.
Thank you very much, and thank you very much for having me. Just a couple of housekeeping things before we get started. Please be sure to remain on mute during the webinar. And please send your questions in the Q&A and not the chat box. We'll do our best to address questions after or during the webinar. In terms of continuing education, it's available through the CDC training and education system, and this is separate from your registration. Instructions will be sent and emailed after the webinar. So today I'm here to talk about STI treatment guidelines, a case-based webinar. I have no financial disclosures. And the structure for today is going to be a little bit different than our usual talks. So we're going to try to make today's talk more interactive. We're going to start by reviewing the current epidemiology of STIs. We're going to describe the important updates in the 2021 STI treatment guidelines as fast as we can. And then we're going to illustrate using different cases how to apply these guidelines to your practice. We'll have 10 different cases available today. We may not make it through all of them, but you'll get to vote on which cases you think are most interesting and that you want to see. So I'm glad that everybody's here today because the truth is that many clinicians don't think about STIs nearly often enough, but they're an epidemic that continues to increase rapidly. Since 2016, this data was just released on Tuesday, there's been a 1% decrease in chlamydia cases, but a 45% increase in gonorrhea cases, and a 52% increase in syphilis cases, and a staggering 235% increase in congenital syphilis cases. So STIs are incredibly prevalent, but in addition to being prevalent, they're also costly. They cost about $16 billion per year, with over $1 billion going to gonorrhea, chlamydia, and syphilis, the most common but easily treatable bacterial sexually transmitted infections. I'll be honest, these numbers that came out in 2020 are actually from during the pandemic. And we really do wonder if they're undercounts because during the pandemic, a lot of facilities were closed or not testing. So this is actually an article that we published describing the availability of sexual health services during the COVID-19 pandemic. And we found that throughout the country, and particularly within the New York and New Jersey regions, many sexual health service sites were closed. Some of this data made it into a modeling exercise done in part by Julia Marcus at Harvard that looked at HIV and STI rates in Atlanta. And they found that if social distancing lasted only 3 months, but service interruption lasted 18 months, which is really what is happening now, as many sites are not still back to full capacity, the 5-year population impact would be an additional almost 900 HIV cases and 57,500 STI cases. And it's important to remember as we see chlamydia cases decreasing, that this may be actually because of a decrease in availability of screening, more so than a true decrease. And that really is consistent with the rises in syphilis and gonorrhea that we do see. And so it's in the context of that the 2021 STI guidelines were released. What's important to note is that it's the first time since 2015, which is a really long time in medicine. They were supposed to be updated in 2020, but were delayed due to COVID. And so because of that, they actually released an update to the gonorrhea guidelines in December, and then released the entire guidelines in July. The guidelines are 192 pages and include 1,455 references. So because they hadn't been updated, there are a lot of major changes in the guidelines. Since we only have an hour today, we'll cover mainly the common things that you're likely to see in your practice if you look for them, with a major focus on changes from the prior guidelines. If there's anything we don't hit or you have any additional questions, please feel free to reach out at the end of the talk. We're going to cover a lot of ground today, but I want to introduce some of the major changes to the guidelines quickly, but I promise these will come up over and over again in our cases. The first are changes to testing. So one of the big changes is that extragenital or 3-site gonorrhea chlamydia testing is emphasized in the guidelines. Previously, it was recommended just for men who have sex with men who reported behaviors that would require testing in those sites. They now actually recommend extragenital testing for both adolescents, women, as well as men who have sex with men. They've also added Mycoplasma genitalium to the guidelines. Previously, Mycoplasma genitalium was an emerging infectious disease in 2015. By 2021, it's fully emerged, and they now recommend testing for Mycoplasma genitalium for individuals with persistent symptoms. Finally, syphilis testing. Not a lot changed in the syphilis guidelines, but one of the big changes is as we see more ocular and otic syphilis, so hearing and vision changes, they actually no longer recommend an LP, and we'll talk about that more later today. In terms of treatment changes, there have been a lot of dosing changes for treatment of STIs since the 2015 guidelines were released. For gonorrhea, the recommendation is ceftriaxone 500 milligrams or 1 gram for weight-based dosing. For chlamydia, it's doxycycline 100 milligrams twice daily for 7 days is the preferred regimen. For trichomonas, it's metronidazole for 7 days in women. For Mycoplasma genitalium, it's sequential treatment with doxycycline followed by moxifloxacin. And for pelvic inflammatory disease, they now recommend routinely adding metronidazole. And all of these will come up throughout our cases. Finally, for prevention, they've liberalized expedited partner therapy, now including not just heterosexual couples, but men who have sex with men as well. And they've also made Cefixime an oral option for gonorrhea, which is also available for expedited partner therapy. Finally, they really focused a lot on prevention in these guidelines, with PEP and PrEP emphasized. And the recent PrEP guidelines suggest informing all sexually active adults and adolescents about PrEP. And so in the context of these changes, we'll talk about what cases you most want to learn from. Can you put up the first poll? And so everyone can vote on what cases they are most interested in hearing about, and we'll go through the top few first. Teresa, yes, the slides can be made available after the lecture. Yeah, so any cases we don't get through today, you'll still get the slides for those and be able to review them on your own. I'll wait till the number of people submitting slows down. It's still moving pretty quickly. And we've clearly created quite a range of cases because we have a lot of different answers, which is fantastic. All right, with about 75%. Jessica, can you end the poll? It won't let me end the poll. Thank you. So for the first poll, we can see that the wow, we have five number one answers. We have a tie for 4 different answers. So why don't we start in that case at the top with a 25-year-old female or cisgender woman positive for genital chlamydia. So this was a 25-year-old woman who presented for routine STI screening. She had no symptoms, was not pregnant, and had no known chronic medical problems. She was screened for STIs, and her lab results showed an HIV test that was negative, an RPR that was non-reactive, a urinary gonorrhea and chlamydia NAT that was chlamydia positive, and a Neisseria gonorrhea NAT that was negative. So with that said, what is the best treatment option for her positive chlamydia test? Jessica, can they see the polls, the answers?
Yes, people are responding.
Right. Oh, sorry, can they see it when it's complete? I meant.
I can share the results once it's
Okay.
complete, yes.
Awesome. Awesome. So as you guys can see, it looks like 85% chose doxycycline, 100 milligrams twice daily for 7 days. 11% chose azithromycin once. 3% chose ceftriaxone. And so the correct answer is actually either azithromycin 1 gram by mouth once or doxycycline 100 milligrams by mouth twice daily for 7 days. And let me explain why. Oh, sorry, she's not pregnant. So actually the correct answer, I apologize, is doxycycline 100 milligrams by mouth twice daily, with azithro being the alternative regimen. So chlamydia infection is the most frequently reported bacterial infectious disease in the United States. This means that numerically, this is actually the biggest change in the guidelines. Previously, the guidelines recommended using either azithromycin or doxycycline for the treatment of chlamydia. However, now doxycycline 100 milligrams twice daily for 7 days is the preferred agent. It's important to know that azithromycin has not been removed from the guidelines, but it has been moved to an alternative regimen. It's there along with levofloxacin, 500 milligrams daily for 7 days. It's really important to remember that azithro remains an alternative regimen because doxycycline is contraindicated in pregnancy. And so azithromycin remains preferred in pregnancy, as well as women who could be pregnant or don't have a pregnancy test and could be pregnant. Erythromycin, which was in the previous iteration of the guidelines, has been removed because of the GI side effects. So this is a pretty impactful change. So why did the treatment recommendations for chlamydia change so much? Well, the first reason is that microbiologic failure for azithromycin versus doxy was higher among men. This was actually a randomized controlled trial that compared oral azithromycin with doxycycline for the treatment of urogenital chlamydia. It was among adolescents in youth correctional facilities, and it was designed to evaluate the non-inferiority of azithromycin to doxycycline. The treatment was directly observed since it was done in a correctional facility setting. The primary endpoint was treatment failure at 28 days after treatment initiation, with treatment failure determined on the basis of nucleic acid amplification testing, sexual history, and outer membrane protein typing. There are 567 enrolled participants. In the context of this closed population receiving directly observed therapy, the efficacy of azithro was 95%, and the efficacy of doxycycline was 100%. This meant that the non-inferiority of azithro was not established. Stated differently, doxycycline might be better than azithro for the treatment of urogenital chlamydia. However, with that said, given the high efficacy rate of azithromycin and the ease of a single dose, this probably would not have been enough to change the guidelines. However, treating rectal chlamydia adequately is also important. And so another major reason for this change is that doxycycline has been found to be superior to azithromycin in 2 recently published randomized controlled trials with a 20 to 26% difference in efficacy. This first study was done in Seattle and Boston. It was a randomized placebo-controlled trial of 177 participants. And a 7-day course of doxycycline, which are the blue lines going up, was significantly more effective than a single dose of azithromycin, the orange lines going down. This other study, also published in the past 18 months, was from Australia. It's another randomized placebo-controlled trial. In this one, again, a 7-day course of doxycycline was significantly more effective than a single dose of azithromycin. So doxycycline is clearly better for rectal infection, but does that matter? Obviously, since I'm talking about this today, the answer is going to be yes. Now, I said earlier, the updated guidelines suggest that rectal screening can be considered for females on the basis of reported sexual behaviors and exposures through a shared clinical decision-making approach. But honestly, receptive anal intercourse is a pretty poor indicator of the need for rectal treatment because it's not just sexual behaviors that matter. Rectal infection is not uncommon among women with genitourinary infection, ranging from 33 to 83%, regardless of behavioral risk factors, likely due to autoinoculation from the urogenital site. If rectal chlamydia is inadequately treated, women are at increased risk for repeat urogenital chlamydia infection through autoinoculation. So as you can see here in this one meta-analysis, the rectal prevalence of CT was in women attending routine clinics was 6%, women at high risk 26%, women reporting anal sex 10%, and women with urogenital chlamydia as high as 77%. And you can see extremely high rates of rectal chlamydia positivity, which is yet another reason for this guideline change. Treating rectal chlamydia is important, not just in men who have sex with men, but women as well. And since doxycycline has been found to be superior to azithromycin, that leads to the change in the recommendations. So when choosing a treatment for chlamydia, you're really trying to balance the efficacy of doxycycline versus the ease of azithromycin. Access is one difference. Many clinics or emergency departments may be unable to provide a 7-day course of doxycycline, while many can provide a single dose of azithromycin. This is particularly challenging for adolescents and young adults. In one study from Washington, D.C., they found that only about 58% of adolescents who had a prescription for an STI treatment filled it. Adherence is a second difference. It's obviously easier to take 1 gram once than it is to take a medication twice a day for 7 days. However, one thing that's really important is that we set our judgments aside. When the gonorrhea updates came out, there was a lot of concern about 7 days versus 1 dose, but I find that most patients can do it, and frequently the ones that can't tell you. Additionally, in the recent randomized controlled trials, azithromycin actually performed so poorly that even in the context of imperfect adherence, doxycycline is likely better for rectal chlamydia. Finally, it's confidentiality. Patients may value not having pills in the house. They may not want a parent or friend or roommate to find out, and being able to treat them at the point of care may be beneficial. So in general, you may want to choose azithromycin in patients who are pregnant or may be pregnant, patients with a history of allergy or intolerance to doxycycline, patients who are unlikely to be adherent, and patients who are unlikely to be able to obtain doxycycline, and azithromycin is available at the point of care. This is a recommended approach that was developed by Hilary Reno from the St. Louis PTC. If there's suspected or possible chlamydia, it really should be doxycycline. If there's a possibility of pregnancy, it should be azithromycin. And if neither of those is true, it's really a shared decision-making approach with doxycycline as the preferred agent. In terms of follow-up for chlamydia, the recommendation is to abstain from sex until partners have completed treatment or 7 days after single dose therapy. To address the question from anonymous attendee, I apologize, there's no name attached. The recommendation is really to consider repeat testing at 4 weeks for rectal chlamydia treated with azithromycin due to lower efficacy. As you saw earlier, genitourinary, the efficacy difference was much smaller. But if you have a patient who either was not rectally screened or a patient who had a positive rectal screen for chlamydia, I would consider repeat testing at 4 weeks. A test of cure at 4 weeks if pregnant, and rescreening everybody at 3 months because reinfection is the most common cause for having a new positive test. So that's our first case, our first chlamydia case. I see a question from CB Brown that says, do you suggest screening for rectal gonorrhea chlamydia for women with no history of receptive anal intercourse? I will tell you that my practice is to offer it to them. A lot of time they'll ask me why, and I'll explain to them this data, and many of them will want to be screened, and I'm happy to do it. And some will decline to be screened, and that's acceptable as well. But I do think it's worthwhile to offer, given that the high rates of rectal chlamydia and gonorrhea, particularly chlamydia, that are seen in women who report no history of receptive anal sex. The other reason I think it's important to offer it is that some women may be hesitant to disclose behaviors. And so by normalizing the offer of it, you make it more acceptable, you reduce stigma. And so I make it a practice to offer 3-site testing to all of my patients and allow them to choose what they think is right for them. So going back to our survey from earlier, it looks like the next highest one was the second case. So we'll go to that one next. This was a 22-year-old cisgender man, positive for oropharyngeal gonorrhea. So this 22-year-old man presents for routine STI screening. He's had oral and insertive receptive anal sex with 3 men in the past 6 months. He has no symptoms. His lab testing shows a urine gonorrhea chlamydia negative, pharyngeal gonorrhea chlamydia positive, rectal gonorrhea chlamydia negative. I'll also mention, because I apologize for deleting them, his HIV test and RPR were both negative and non-reactive respectively. So he has a positive pharyngeal test for gonorrhea. So the question is, what is the best treatment for his positive gonorrhea test? Amazing. So it looks like we have a relatively split answer. We have 67% choosing ceftriaxone 500 milligrams once, 25% choosing ceftriaxone 500 milligrams once with doxycycline, 100 milligrams twice daily for 7 days, and then a smattering of other responses. So let's highlight the new gonorrhea treatment guidelines. So the new gonorrhea treatment guidelines recommend ceftriaxone 500 milligrams IM once, and for persons weighing greater than 150 kilograms, 1 gram of IM ceftriaxone. They also say if chlamydia has not been excluded, treat for chlamydia with doxycycline 100 milligrams PO twice daily for 7 days. And so I want to highlight that in this case, he actually was negative for chlamydia because he had a gonorrhea chlamydia test that was only positive for gonorrhea. And so as chlamydia was excluded, I think it would be reasonable to treat only with ceftriaxone. And so the ceftriaxone 500 milligrams is the correct answer. In addition to that, in the new gonorrhea treatment guidelines, we do have 3 alternative regimens. The first is our traditional regimen for patients with true allergies to beta-lactam antibiotics or ceftriaxone, which is gentamicin 240 milligrams IM times 1 and azithromycin 2 grams. The second is cefixime 800 milligrams orally times 1. I do want to highlight this one for a second. For those who remember cefixime from previous iterations of the guidelines, this is a higher dose, and cefixime resistance has come down since we're using it less. However, while this is a possible regimen, we know that cefixime does not provide as high or as sustained bactericidal blood levels as ceftriaxone. It also demonstrates limited treatment efficacy for pharyngeal gonorrhea, and therefore we should be careful about using it, and it probably would not be a good choice in this patient with pharyngeal gonorrhea. Finally, there's considerable quinolone resistance amongst gonorrhea isolates, but in an example of resistance-guided testing, if you're at a site that has GRA testing, a marker for quinolone resistance, and it's negative, using ciprofloxacin would be a reasonable option. Currently, very few places have this, but there are a lot of commercial labs developing resistance-guided testing, and I expect before the next iteration of the guidelines, many more sites will have the availability to do this type of testing. Just as a reminder, none of these really are reliable alternatives for pharyngeal gonorrhea, and so it really is best to use ceftriaxone whenever possible. So we've changed the guidelines for gonorrhea to remove azithromycin routinely, right? In the previous iteration of the guidelines, everyone got ceftriaxone and azithromycin. Now it's ceftriaxone only and doxycycline if you're treating gonorrhea and chlamydia or potential chlamydia. But the question is, why make this change? So there's really 2 reasons. The first is antimicrobial stewardship, and the second is pharmacokinetics and thermodynamics. The first reason, antimicrobial stewardship. Since the publication of the 2015 STD treatment guidelines, concerns about antimicrobial resistance have increased dramatically. In particular, there's a lot of worry about the impact of antimicrobial use on the microbiome and data indicating azithromycin resistance for gonorrhea and other organisms. So if you look here at the dark blue boxes, that's resistance to gonorrhea. And since 2013, it's increased more than 7-fold in just 5 years. So the first reason to remove azithromycin from the guidelines is that it's less likely to provide an added benefit in treating gonorrhea, and we're developing more and more resistance to it. The second is rising resistance in other pathogens. So things like Salmonella, Shigella, and Campylobacter are incredibly common and even asymptomatic in many patients. We're seeing more and more drug resistance to them, particularly to azithromycin. And so reducing exposure to azithromycin is important to reverse the increases in drug resistance we're seeing amongst these enteric pathogens. The third reason is actually selection for non-macrolide resistance. So this was actually a study done that looked at the mass distribution of azithromycin to preschool children twice yearly for 2 years in sub-Saharan Africa. And in that study, azithromycin was actually shown to reduce childhood mortality, but at the cost of amplifying macrolide resistance. But it wasn't just macrolide resistance. Continued mass azithromycin distributions also selected for non-macrolide resistance, including resistance to beta-lactams like ceftriaxone. So really this concern about resistance is why they removed the recommendation for dual therapy with azithromycin. But why did they increase the dose of ceftriaxone from 250 milligrams to 500 milligrams? So the second major category is pharmacokinetics and thermodynamics, or PK/PD. Pharmacokinetic and thermodynamic modeling has really affected our understanding of antimicrobial dosing for Neisseria gonorrhea. One thing we know is that worldwide, we're seeing a rise in the minimal inhibitory concentration of, or MICs for ceftriaxone. The MIC is the lowest concentration of an antibiotic that inhibits the growth of a given strain of bacteria. So as the MIC goes up, more drug is needed. Ceftriaxone levels need to be greater than the gonorrhea MIC for about 24 hours. And there's a national surveillance network that monitors gonorrhea MICs. And while we haven't seen MIC creep in this country, it has been seen in other countries. In fact, in Australia, they increased to 500 milligrams almost 3 years ago. And in England, where they've seen several cases of highly resistant gonorrhea, they've increased to 1 gram without azithromycin. The second issue occurs in the pharynx. There are 2 reasons we're concerned about the pharynx in particular. The pharynx tends to be screened less than other anatomic sites. And globally, most reported ceftriaxone-based failures have involved treatment of pharyngeal gonorrhea. Ceftriaxone concentrations also tend to be more variable in the pharynx. And given that you need, for treatment of Neisseria gonorrhea, you need the drug level to be above the MIC for over 24 hours, variable drug levels can be really hard to overcome. And so the hope is that by increasing the dose of ceftriaxone to 500 milligrams, you can provide longer time above the MIC. And so with that, we've talked about pharyngeal gonorrhea. So our patient in this case had pharyngeal gonorrhea on his GCCT test. He was treated with IM ceftriaxone. The next question is, when should he follow up for retesting? Jessica? Thank you.
Sorry about that.
That's okay. Amazing. So again, a smattering of answers. I see 10% saying 1 to 2 weeks, 49% saying 4 weeks, 6% saying 8 weeks, and 36% saying 12 weeks. So this is fantastic because actually the 10% group is the one that's correct, 1 to 2 weeks. So let's talk a little bit about follow-up of gonorrhea. So once you make the diagnosis and treat gonorrhea, the next step is to understanding follow-up care. Unchanged from before is to abstain from sex until 7 days after completing treatment. We should be assessing for treatment failure if patients have persistent symptoms 3 to 5 days after treatment. And if they do, we should be doing a culture with antimicrobial susceptibility testing and another nucleic acid amplification test. A new recommendation in the 2021 guidelines is a test of cure for all pharyngeal infections at 7 to 14 days. So I very frequently get asked, do I really need to do extragenital testing if I'm going to treat this person empirically? And one of the many reasons I say yes is that it changes your follow-up management. If you treat with azithromycin and they have rectal chlamydia, I might follow up more frequently. If they have pharyngeal gonorrhea, I should be doing a test of cure at 7 to 14 days. We should be doing a test of cure at 4 weeks if pregnant, and everyone should always be rescreened at 3 months due to high rates of reinfection. One thing I often get asked when I mention 7 to 14 days is, are we just going to pick up non-viable organisms? Are we really going to know whether the patient's truly positive? I see ZB Brown is asking the exact question I'm about to answer. So we know that persistent non-viable organisms can cause false positive results. However, reinfection from re-exposures are a much more common cause for a persistent positive gonorrhea test. If you look here, the RNA NAT, which is the one most commonly used by most sites these days, you can see that even 0 to 7 days after treatment, the positivity is about 8.7%. At 8 to 14 days, it's 2.2%. And in greater than 15 days, it's about 1%. And so I always recommend retesting closer to the 14-day end of that window, about 2 weeks. But again, you would not expect too many false positive results, even at days 8 through 14. So what if the test of cure is positive? So again, the most important thing to know is that the most common cause of treatment failures are actually reinfections. Taking a good history, finding out if patients were sexually active since you last saw them, if they had the same partners who maybe weren't treated, is the best way to assess for reinfection. If reinfection is unlikely, the recommendation is to obtain a simultaneous gnat and gonorrhea culture, to alert public health authorities that you could have a resistant case, and then to treat with either ceftriaxone a second time or gentamicin azithromycin. In general, I will use ceftriaxone twice before I go to gentamicin and azithromycin as an alternative regimen. If an alternative regimen is used, in the pharynx, it's still 7 to 14 days. If you use the alternative regimen for other sites, it's still the 3-month follow-up. Sorry. So going back to our cases and going back to our survey from before, it looks like our next highest one with 13% was the 22-year-old cisgender man with persistent dysuria. So this is a 22-year-old bisexual male who came in complaining of dysuria and penile discharge. He actually received empiric treatment with ceftriaxone and doxycycline as per our updated guidelines. And testing for gonorrhea and chlamydia returned negative. And he continued to have dysuria 1 week after the end of therapy. So the question is, what would you want to test for next? All right, so it looks like about 28% said chlamydia, about 59% said Mycoplasma genitalium, 6% said trichomonas, 5% said HSV, 1% said Neisseria meningitidis. So as a reminder, this patient was tested for gonorrhea and chlamydia and was negative at all 3 sites. And so with negative testing for gonorrhea and chlamydia, we do need to think about non-gonococcal causes of urethritis. The most common non-gonococcal cause is chlamydia. But again, he was previously tested and was negative, and PCR testing or NAT testing is very sensitive. Mycoplasma genitalium, something that went from an emerging pathogen in 2015 to having its own section in 2021, is something that should definitely be considered. And it's highly prevalent in persistent urethritis. If you look, it's actually more common than things like Trichomonas vaginalis that we think about more commonly. Trichomonas is more common in men who have sex with women. And so it's also something to think about here because he is bisexual and does have sex with men and women. Also on the list are things like Neisseria meningitidis that were added to the guidelines this year, other bacteria like H. flu, viruses like adenovirus and EBV, and an acknowledgement that some cases of non-gonococcal urethritis, as much as 50% will be unknown. That's particularly prevalent among women with cervicitis. And so it's important to recognize that you may not identify a pathogen because it may not be infectious. So because he was a bisexual male, we tested him for Trichomonas and Mycoplasma genitalium, and his Mycoplasma genitalium test came back positive. And so I really love Mycoplasma genitalium. Since it's likely a new pathogen to many people, this slide is my everything you need to know about Mycoplasma genitalium slide. We should be thinking about Mycoplasma genitalium in patients with recurrent non-gonococcal urethritis or cervicitis, or persistent epididymitis or proctitis. We can think about testing in PID, but they do not recommend asymptomatic screening at all. It can be tested using an FDA-approved genital and urinary NAT and is often on the same platforms as chlamydia, gonorrhea, and trichomonas testing. It's important to note that we're seeing significant amounts of drug resistance, with macrolide resistance ranging from 44 to 90%, and quinolone resistance up to 15%. Treatment, as you'll see, is with resistance-guided therapy, and sex partners of symptomatic persons are tested, treated only if they're positive. So Mycoplasma genitalium is surprisingly common. In this study, they looked at men with urethritis symptoms who were enrolled in 6 STD clinics from 2017 to 2018, and actually found that more than 1 in 4 men with urethritis were tested positive for Mycoplasma genitalium. And so it's important to know that it's incredibly common, and we don't really know what the role of asymptomatic colonization is, which is why the recommendations are really only to test for it if you're symptomatic, in order to reduce the amount of antibiotic exposure people have. In terms of treatment, this is another example of the guidelines using resistance-guided treatment. The recommendation is always to start with doxycycline to reduce the bacterial load. If macrolide sensitivity is available, you can use azithromycin. However, in most cases, macrolide sensitivity will not be available, and the recommendation is moxifloxacin twice daily for 7 days. In summary, we should be testing for Mycoplasma genitalium in men and women with recurrent or persistent non-gonococcal urethritis, cervicitis, epididymitis, or proctitis. We can think about it in patients with PID, particularly ones who are not improving. Asymptomatic screening is not recommended. You can do it on the same FDA-approved genital or urinary NAT that you're using for gonorrhea, chlamydia, and trichomonas testing. Treatment is most commonly doxycycline, followed by moxifloxacin. And sex partners of symptomatic persons are treated only if positive. And with that, we'll go back here. And our fourth and final case that was tied with the most is the 18-year-old cisgender woman with an unfaithful partner. So this is our 18-year-old bisexual female who came in for routine STI screening. She has no symptoms, but her partner recently admitted to being unfaithful. She mentioned that they'd worked things out and are actually back together, but she did want to get tested for STIs because her partner has not been going to get tested. So she received our routine screening testing with HIV, RPR, urine, pharyngeal, and rectal GCCTs, and was positive for urinary and rectal chlamydia. So the next question is, what is the best treatment for her positive chlamydia test? All right, and it looks like we have a split answer with 83% choosing doxycycline and 14% choosing azithromycin. And this is actually the case I was thinking about earlier. So I purposefully did not give you a pregnancy test result for her. So in clinical practice, I would normally do a point of care urine pregnancy. And if that was negative, would do doxycycline. And we can, yeah, exactly. So if someone just posted a urine HCG. So I would normally do a pregnancy test, and if that was negative, and then I would do a point of care, give her doxycycline. If I was unable to get a pregnancy test for whatever reason, I would give her azithromycin 1 gram. And so I think both in this case are appropriate answers. Because I didn't know what order you would pick the cases in. We've already reviewed these slides, and so I won't review them again. But we talked about her chlamydia. We treated her with doxycycline or azithromycin, depending on her pregnancy status. Is there anything we can do to reduce her chances of reinfection? And for this one, we don't have a survey question, but you can just type your answers in the chat. Is there anything we could do to reduce her chances of reinfection? I see someone saying, get rid of the partner, treat her partner. I see EPT in the question and answer, EPT. Education, 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 thorough education, meet her where she is, EPT, no sex, treat partner, condoms. So these are all absolutely the right answers, and they're all things we should be doing. So, routinely in our clinic, we provide patients education. We have a bowl of condoms by the door that patients are welcome to. But I think that meeting the patients where they are is exactly what's really important here. So you want to provide education, you want to provide condoms, but you also want to make sure the partner's treated. So I'd mentioned earlier that the partner did not want to come in for testing or testing. And so the question is, now that we know that she has chlamydia, likely from this partner, what can we do about it? And those who said EPT is exactly what we were looking for. So reinfection is the most common reason for recurrent infections. And to reduce the risk for that with patients for gonorrhea and chlamydia, the CDC actually recommends management of sex partners and expedited partner therapy. It's exciting that EPT is now permissible or potentially allowable in all 50 states and not prohibited in any. While EPT is an option when managing sex partners, the primary goal remains trying to get the patient into clinic for evaluation. Sometimes you can have partners come in with the patients when they come in for treatment, and that's a great way to get people to come into care. Having the partners come into clinic is important because partners may need more than just treatment. A visit is a chance to provide comprehensive sexual health services, including HIV and syphilis testing, and discussions around HIV prevention for the partner. If partners are unable to come in promptly or at all, expedited partner therapy as a second approach or as a harm reduction strategy should be considered. And so for the management of sex partners, we should be evaluating all sex partners in person if we can. If not, we should be offering empiric treatment to all partners in the last 60 days, or the most recent partner if the last contact was greater than 60 days ago. Expedited partner therapy was previously only recommended for heterosexual couples. However, in the 2021 guidelines, they expanded that to include men who have sex with men using a shared decision-making approach. And so really the only people who should not be offered expedited partner therapy are those who can currently test positive for syphilis. So anyone who tests positive for gonorrhea and chlamydia and not syphilis should be offered EPT if their partners are unable or unavailable to come in for testing and treatment. So now that we know we want to give her expedited partner therapy, what's the best drug for expedited partner therapy? Awesome. So we have another relatively split result. We have 61% saying azithromycin and 39% saying doxycycline. And in this case, everyone is right. So for expedited partner therapy and treatment of gonorrhea, the treatment is cefixime 800 milligrams times 1. For chlamydia, this is actually different than most of the other guidelines, where there is no recommended or alternative agent specifically for EPT and chlamydia. For chlamydia, the options are either doxycycline, 100 milligrams twice daily for 7 days, or azithromycin 1 gram once. One of the challenges is that most studies of EPT use azithromycin, so that's where most of the evidence is. In general, my method is a shared decision-making approach, and I encourage partners to take doxycycline when rectal infection is likely and pregnancy is unlikely. I use doxycycline for most men who have sex with men. I will often use azithromycin for men who have sex with women. And for women who have sex with men, it really depends on how confident I feel about their pregnancy status and if I can speak with them directly, but often default to azithromycin when I can't. With that said, what's clear is there's really no easy algorithm for providing EPT, which supports the shared decision-making approach being the best approach. So as a reminder, previously expedited partner therapy in 2015 was really only recommended in heterosexual couples due to the concern about HIV. It was actually not recommended in men who have sex with men. While the data is limited on the effectiveness of EPT for men who have sex with men, it is an additional option when needed. This change was actually in part from an abstract from Julie Schillinger from the New York City DOH. In a retrospective cohort of almost 4,400 visits by men who have sex with men who presented as contacts of patients diagnosed with chlamydia or gonorrhea, 14% of visits resulted in a bacterial STI diagnosis other than the one of the two they came in for. That really highlights the importance of having patients come in for testing, because just because they were exposed for chlamydia does not mean they won't test positive for gonorrhea. However, among those with chlamydia contact, HIV was diagnosed at only 8 or 0.2% of visits, highlighting the potential benefits of EPT for men who have sex with men and the change in the guidelines, where now EPT is recommended for men who have sex with men using a shared clinical decision-making approach. So in summary of EPT, we should be evaluating all sex partners. We should be empirically treating all partners less than 60 days, or the most recent partner if the last contact was greater than 60 days. Expedited partner therapy is really available for everyone now. And the treatment is for gonorrhea cefixime and for chlamydia azithromycin or doxycycline. But last but not least, what can we do to reduce her chances of acquiring HIV? And you can again type your answers in the chat. I see pep prep, condoms, pep prep. Excellent. Education, condoms, and PrEP, all correct answers, and that's exactly where we're going here. So while we're talking about the 2021 STI guidelines today, it's important to know that they also released a 2021 update to the pre-exposure prophylaxis guidelines. And the way I summarize the changes to these guidelines are really simply. They recommend discussing PrEP with more people, doing more HIV testing, and expanded PrEP options to appeal to more people with tailored recommendations based on those new options. What's really important are the first two here. Anyone we're testing for STIs, we should be doing more HIV testing on. We should not be STI testing without HIV, and honestly, given syphilis rates, syphilis testing as well. The other thing is the new recommendation is actually to inform all sexually active adults and adolescents about PrEP. And this is something we don't do well. Risk-based screening tools and algorithms don't work in stigmatized patients. Universal HIV and STI screening and PrEP education is more beneficial and cost-effective than risk-based screening. So based on this, we really should be informing all of our sexually active patients, both those getting STI testing and those not, about PrEP and allowing them to make their own decisions. So those were our top four cases. Our fifth case was our 32-year-old, or sorry, our 23-year-old cisgender man with a rash. Yes. All right. So this case is a 23-year-old man taking TDF-FTC4 PrEP who presents for an urgent care visit due to rash. I see someone with more training in PrEP, which we can definitely help provide. 23-year-old taking TDF-FTC for PrEP presents for an urgent care visit due to rash. The rash involves his chest, back, palms, and soles. He has no headache or other symptoms. Lab testing shows an HIV antibody antigen test that's negative, an RPR of 1 to 256, a treponema antibody that's positive, and 3-site GCCT testing that's negative. What is the next best step in management? All right, so again, pretty evenly split with 51% saying treatment with long-acting PENG once and 44% saying long-acting PENG once weekly for 3 weeks. And so what's important to know in this case is that he's presenting with secondary syphilis. And so this is really a common area for discussion because you don't have a prior RPR titer here. So without a prior RPR titer, you do wonder a little bit about could this be latent syphilis? However, in this case, it's not latent. He has active secondary syphilis, and so the appropriate treatment is 1 dose of penicillin G, and we'll talk about that coming up. Just as a reminder, these are the general screening recommendations for syphilis. I don't know if these are always the best recommendations. You know, syphilis cases have been increasing year over year. We've had another greater than 50% increase since 2016. And so I think one thing that's really important is that any time we're screening for STIs, we should be screening for HIV and syphilis as well. So if we're worried enough to screen for STIs, we should include HIV and syphilis in that. Outside of that, men who have sex with men should be screened at least yearly or every 3 to 6 months based on increased risk. Patients taking PrEP every 3 to 6 months based on risk. Persons living with HIV at least annually and every 3 to 6 months of increased risk. For non-pregnant women, there's no national recommendation for routine screening. Screening at least annually is recommended in sexually active persons if at increased risk. And again, you know, given how quickly our rates of congenital syphilis are increasing, I do recommend that if we're screening women for STIs, we screen them for syphilis as well. For pregnant women, the recommendations are now the first prenatal encounter, plus the 3rd trimester and at delivery of increased risk. And many states and city health departments have actually made the 3rd and at delivery mandatory for everybody to both reduce stigma, but reduce missed opportunities for early identification of congenital syphilis. In terms of staging syphilis, this diagram is from the New York City STD Prevention Training Center syphilis monograph, and it really outlines the stages of syphilis well. Before we talk about treatment, you need to understand staging. And so it starts with the incubation period, which can be up to 90 days. So keep in mind that the incubation period can be up to 90 days, which means if the patient comes and tells you they were exposed to syphilis, in the last 90 days, their testing could be negative. And so you should empirically treat them. Primary syphilis is identified by local symptoms, traditionally the painless chancres that we think of as typical for syphilis that occurs at the site of inoculation. It's important to note that the updated STI guidelines do highlight that primary syphilis can present atypically with either painful or multiple lesions. I also like to highlight the fact that these are painless ulcers, which means if they're not in an easily visible spot, like the rectum, vagina, or oral cavity, they may not be noticed. Secondary syphilis has symptoms. This is what we generally think about as rashes on the palms and soles, or other disseminated symptoms like fevers, chills, hepatitis, and others. Latent syphilis is by definition asymptomatic. Early latent is when it's possible to document a non-reactive syphilis serology within the past year, or a history of symptoms within the past year. Otherwise, the disease is considered late latent or latent of unknown duration. But remember that latent syphilis requires the patient to be asymptomatic. These designations are important because they directly determine what is adequate treatment for syphilis. And so in treating syphilis, you treat by stage. These are the standard treatment guidelines, both in or not within pregnancy. And the first thing I want you to notice, these are the standard treatment guidelines for syphilis. Remember that there is no alternative treatments for pregnant women. The alternative treatments are only for non-pregnant women and men. In terms of treating syphilis for incubation, primary, secondary, and early latent, it's Pen-G IM once. So our patient that had secondary syphilis would need 1 injection. For those with late latent or latent of unknown duration, it's Pen-G IM weekly for 3 weeks. For neuroocular otic syphilis or tertiary syphilis, it's IV penicillin for 10 to 14 days. One of the questions we get most commonly is, how do I interpret syphilis titers? And so while in this case, there's no need to interpret titers because he had secondary syphilis, I will highlight it. Quantitative testing involves serial dilution of serum specimens to determine the amount of non-treponemal antibody present. Non-treponemal test titers are used to follow treatment response and look for reinfection. So what you're really looking for is a 4-fold increase in the non-treponemal titer after treatment. A 4-fold change is equivalent to 2 dilutions and is considered necessary to demonstrate a clinically significant change. So for example, if you go from 1 to 16 to 1 to 32, that's a 1 dilution or 2-fold increase or decrease. As compared to 1 to 8 or 1 to 32, or 1 to 8 to 1 to 32, or 1 to 32 to 1 to 8, which is a 2 dilution or 4-fold increase or decrease in titers. Remember that non-treponemal titers usually decline after treatment and may become non-reactive with time. However, in many people, non-treponemal antibodies persist for a long time, a response referred to as serofast. What do we do if their titers don't respond? So a lack of a 4-fold decline in titers after 12 months for early syphilis and 24 months for late syphilis, we need to be screening for neurological signs and symptoms, and if they have them, perform a lumbar puncture. Think about whether the patient could have reinfected. Do they have risk factors? If so, we should retreat. If both the above are negative, you can either follow the patient carefully or give additional therapy. Several observational studies show no benefit in additional antibiotics. However, if you have a 4-fold increase in titers after appropriate therapy, we should always be screening for neurological signs and symptoms, and if yes, performing an LP, thinking about whether the patient could have been reinfected, and if yes, treating. And if the patient denies the possibility of reinfection and the titer continues to be elevated, again, think about performing an LP because neurosyphilis can be a cause of RPRs failing to respond. And with that, we'll go back to our cases. All right, and we have time for one more case, I think. And our next highest case was 18-year-old cisgender female for annual physical. Please remember, you will receive all of these cases, so you will have all of them after this. So this is an 18-year-old female who presents for an annual physical for participation in a rec sports league. And the question is, should you take a sexual history? And hopefully, because you're here today, you know that the answer is yes. But I want to highlight the fact that the CDC also updated their guide to taking a sexual history. They recommend a sexual history be taken as part of routine care. And a sexual history allows you to provide high quality care by assessing and screening for a broad range of sexual health concerns. They've also updated some of the questions, like do you have sex with men, women, or both, to be more gender neutral. What is the gender or genders of your sex partners? Are you currently having sex of any kind? And if so, oral, vaginal, or anal with anyone? The CDC continues to recommend the 5 Ps, but they've updated them both to be more current, including pregnancy intention, as well as be more gender neutral. And I highly recommend that everybody reads it. Because when you take a sexual history, you really never know what you're going to find out. So this patient came in for a sports physical, but once you made them feel comfortable and asked, they have to be honest. It hurts when I pee. So what is our empiric treatment for dysuria? All right, Jessica, in the interest of time, we can stop it there, even though people are still answering. But it looks like about half said ceftriaxone and doxycycline, and that is the right answer. In this case, the patient does not have testing yet. We're treating her empirically, and so we should treat with ceftriaxone 500 milligrams and doxycycline because chlamydia has not been excluded. But what if you have a gram stain? So in her case, we did labs, HIV testing, syphilis testing, and a gram stain of the urethral discharge. That showed gram-negative intracellular diphthococci consistent with gonorrhea. I'm going to skip the next question because we're running out of time, but this is a really common chlamydia question I wanted to highlight. Should she receive treatment for both gonorrhea and chlamydia if the gonorrhea is known, like from a gram stain, and chlamydia testing is pending? And the truth is, there's really no right answer. It's really just a question of clinical judgment. The CDC recommends including a regimen for chlamydia infection if chlamydia has not been excluded, but you can consider the setting, how easy it will be to reach and treat the patient when results return. For example, with patients of ours who've been our patients for long periods of time that we have their cell phone number and they come in regularly, we'll often treat them just for gonorrhea in that case and call them if they have chlamydia. In patients we see in urgent care or walk-ins who we've never seen before, we'll often treat with both ceftriaxone and chlamydia, or with ceftriaxone and doxycycline. And so she received ceftriaxone 500 milligrams IM times 1. We attempt to call her, but can't reach her. 3 weeks later, she returns with ongoing dysuria and abdominal pain. Her exam has cervical motion tenderness, and her overall picture is consistent with mild to moderate pelvic inflammatory disease. And so here's the new regimen for PID. The big difference is actually the addition of metronidazole. The previous iteration of the guidelines recommended you could or could not include metronidazole, but it's now recommended that metronidazole be included in all cases of PID. For mild or moderate disease, it's ceftriaxone dosed for gonorrhea, along with doxycycline and metronidazole. For severe disease, it's IV ceftriaxone along with doxy and metro. And this is the study for that. And this is the list of cases for beta-lactam allergy. And again, you'll be receiving all these slides after today's presentation. And with that, I just want to remind everyone what we went through today. We talked about extragenital gonorrhea and chlamydia testing, thinking about Mycoplasma genitalium for persistent symptoms, and syphilis not needing an LP with ocular otosyphilis, although we didn't get to that case today, I'm sorry. For treatment, gonorrhea, ceftriaxone 500 milligrams, chlamydia, doxycycline being preferred. For trichomonas, it's metronidazole for 7 days in women. For Mycoplasma genitalium, it's resistance-directed sequential therapy. And for PID, adding metronidazole routinely. For prevention, more liberal expedited partner therapy, including men who have sex with men, and inform all sexually active adults and adolescents about PrEP. As a reminder from the New York City STI Prevention Training Center, you can reach us anytime through our clinical consultation warm line if you have questions. And I will stay for a couple minutes just to answer the questions in the chat. And thank you all for joining. And I'm sorry we ran over, but we were having too much fun.
Thanks so much, Dr. Zucker. There were a few questions in the Q&A tab. I don't know if you want to take a look at those.
Yeah, okay, so let's see. So if someone has been treated with doxy for urethritis but persists, then positive. So that's a great question, Leo, and that comes up a lot. Our general recommendation is that if it's been within 7 days since the end of their treatment for doxycycline, you can just start the moxifloxacin. On the other hand, if it's been more than 7 days since they completed their course of doxycycline, then you really should restart with another course of doxy and then moxifloxacin. How reliable is current testing for MGen? So I don't have the exact numbers for you, but my understanding is it's pretty sensitive. It's a NAT that's FDA approved, so it's no longer the lab-derived test it used to be. It's an FDA-approved NAT that's available on at least 2 of the major STI testing platforms, the same ones that most major institutions use for gonorrhea, chlamydia, trichomonas, and other testing. Susan, I apologize. I'm not sure urine testing versus culture testing for gonorrhea, chlamydia, in females. I apologize. If you're still here, I'm happy to answer. I'm just not sure I understand the question. Somebody's asking about ICD-10 codes. I can add those to the presentation before we send them out. And then if the incubation period is 9 to 90 days, contacts of syphilis cases who last sexual encounter was more than 98 days ago, do we need to test before treatment? And so the answer to that is yes and no. I think it's always good to get a baseline RPR, but you don't need to wait for the results before treating. So I think of that almost like post-exposure prophylaxis for those patients. When they come into clinic, I'll get an RPR so I have a baseline and I know what's going on, but I'll also treat them on that day without waiting for the results to return.
And then Dr. Zucker, there were 2 questions that were asked in the chat. I don't know if you have time for that.
Sure.
Okay. One question was, we are part of a state pilot project and have started testing everyone for MGEM, symptomatic or asymptomatic.
Okay.
Should everyone be treated even if no symptoms?
So I'm an infectious disease person by training. So I would say absolutely not. I think it's going to lead to a lot of overtreatment. It's also very hard to treat MGen already. You know, we have a lot of macrolide resistance. We're already using sequential treatment. I would highly recommend not doing it unless patients are actually symptomatic. I will say that in our lab here, we're working on bringing it in-house. And I'm trying to do a sort of tiered process where for symptomatic patients, if they test negative for gonorrhea and chlamydia, they automatically get tested for MGen. But I would not do it routinely as first line. I certainly would not treat it unless patients were symptomatic, just due to the difficulty of treating it and the concern about increasing resistance. And you said there was another question in the chat, Gary?
Yeah, I'm not sure if I'm capturing this question correctly, but the question was, which test is better for sexually active females? Chlamydia, gonorrhea, UA, or swabbing?
Got it. And is that from Susan Lasker, who's also asking it in the Q&A as well?
No, it's actually a different participant.
Okay. So I think that's the same question that Susan Lasker is asking. I'd have to go back and look. I know for a while the UA was considered less sensitive than the cervical swab. My understanding now is that they're pretty close. The new NATs are pretty sensitive. I'd have to look to see exactly what the difference is. Most people will routinely use urine if they're not planning to do a pap smear or other type of cervical option. The other option always is a self-collected vaginal swab, which many sites also use as well. I'll have to look for you for the exact difference in sensitivity. I know that the cervical is more sensitive, but I don't think enough worth doing cervical swabs on people who aren't going to need invasive vaginal exams anyway.
Great, thank you. And there's just a comment in the chat saying, just to confirm, all gonorrhea cases should be tested for cure within 2 weeks of treatment.
That's correct.
Okay, great.
Yeah. And I see Larry saying that they do vaginal swabs routinely, which is also another option, a very reasonable option. It doesn't require the invasive exam that sometimes a cervical swab would require.
Well, thank you so much, Dr. Zucker, for your presentation today. It was really great to have all these questions. And I'd like to thank the audience for joining us today and asking all these questions. We hope to see you on a future training. And as a reminder, we will be sending out a copy of the slides and CE instructions, and the recording will be posted on our website in the next week. Thanks so much.